So you heard a little bit about me, and you heard I'm based in New York. I was born in the US in Oklahoma, but I moved to London when I was small, and so I have a British accent. I lived in London for 20 years or so and worked in academic publishing, in education, and then I came to New York 20 years ago this summer and eventually started working at Consumer Reports and led health there, and learned a lot about health at Consumer Reports, particularly the importance of trust. The Consumer Reports brand is perhaps the most trusted brand in the United States, which is an incredible privilege to work in that context where there are no commercial conflicts of interest, the ability to tell truth to power. And in the process of doing that and in being successful influencing the marketplace in the US, I really came to understand that trust was so often a vital element of change and of culture change, and certainly that's the case in healthcare. And so I left Consumer Reports 18 months ago to set up on my own and try and explore this further and work with leaders in healthcare systems to help them reflect on trust and integrate the notion of trustworthiness into their medical education, their institutional policies, and their personal practice. And this is certainly a work in progress for me. But you know, we all know trust exists at so many levels, at the interpersonal level, which can be the doctor-patient relationship, and at the institutional level, trust in our institutions locally, globally. But you know, we all know that trust is so under siege right now. Multiple studies from centers like Pew and Edelman, the communications research firm, show that trust is in crisis. And it's at an all-time low in the US and I believe in the UK and some other Western countries. Trust in media is down, trust in science and experts. It's all under assault while we are left trying to make sense of what is trustworthy, who to trust, what's fake news, what isn't, who should we believe. So this type of erosion in trust at the highest level of our democracy is trickling down to the interpersonal, individual level. And we all need to start talking about it more and attempting to address it together. Because sometimes this distrust is justified, sometimes it's not. But until we tackle it and work hard to earn it and demonstrate trustworthiness, our work will not transform practice and outcomes. We're going to hit a wall in the work that we're doing. So some of the research in trust in recent years has really sort of identified the core as a thing about well-being. So in our modern society, which is very institutionalized, we place our trust in institutions. So that can be government, media, NGOs, institutions like that, and their leaders. And that's because they're the ones in whom we've vested power over our lives, our money, our safety, and so on. And so we need to trust these institutions to act with integrity and keep our interests in mind. Otherwise, there's a lot of fear when that starts to be eroded. And, you know, we need trust for society to benefit. And yet there are so many barriers to trust. There always have been, but these seem more intense now that we have Trump and a culture of distrust in social media and so on. There are so many barriers. I've picked a few. I don't have all the answers, and I want you to reflect on what you think the barriers are. But, you know, beliefs are clearly one, a lack of shared values. So in healthcare, it could be the reproductive rights example, that do you do screening in early pregnancy? What do people believe about how to intervene in pregnancy? Or at the end of life, what are people's faith-based beliefs, and how does that impact their trust in a doctor about end-of-life care? What are your biases? Are you working with someone who might be racist? Are you working with someone that makes assumptions about your gender based on how you present yourself? Then there's the barrier of fear of harm, fear that if you don't do anything, something bad will happen. Fear, as we heard just now, around defensive medicine, and the fear we'll get in trouble if we miss something. Fear of punishment, that we will be punished if we miss something. So all these things get in the way of our trusted relationships when we're afraid of each other. And then perhaps the worst of them, greed, And as we heard before, the kind of medical industrial complex, where a culture where misaligned incentives are in place. In the US and the countries where you're paid for volume and paid for productivity and not for outcomes. And these conflicted business models that we've also heard about already, where people make money from working with drug companies and so on. So if you're a patient and you're faced with all of this, you're really disempowered. There's a business consultant in the US called Charles Green, who I'll credit for what I find a very useful equation to use in healthcare, called the trust equation. It's really the sum of your credibility, your reliability, your intimacy, over your ability to be oriented towards yourself or towards others. So to the extent that you're selfish, you take away from trust. And I'm going to break this down a little bit more. If you think about credibility, and this applies in the whole world and in health at every level, institutional, individual, do we have proof that our words carry credibility? Are we truly experts? Reliability. Do our actions over time demonstrate our reliability? What's our performance record, our track record? Then intimacy, which is something that isn't really talked about in medical school, but are we really listening to each other, and are we allowing ourselves to be vulnerable, which is something very new to doctors who've been brought up to have strong egos and think that they are meant to be the authority figures and to not demonstrate their own vulnerability. Yet that's so essential in trust. And then is our focus on the needs of others? Are we showing altruism? So all those things we need to keep in mind as practitioners and researchers and leaders. And that's a kind of a big emotional burden for us. We're not just scientists. So trust in healthcare. When there's been a survey by Edelman, the company I mentioned before, that noticed that trust is the most important aspect that patients and citizens report when they talk about engagement in healthcare. So if you want to have a relationship with a citizen to talk about health, there must be trust. It's stronger than anything else. But in the healthcare system, there are so many players. There are these influences spinning around us, this doctor-patient relationship in the middle. The influences of news, of information, of advertising, of myths, of conflicts of interest, of hidden agendas, of people that pay for healthcare and have a need for a return on investment, and people manufacturing things to sell to you. They're all sending messages to you, and you have to make sense of whether to trust them, and there's good reason not to. And then at the heart, the clinician-patient relationship, where a clinician needs to have the skills, not only the clinical skills, but the interpersonal skills and the performance record. There's just a lot going on. I mean, there's complexity. And to try and isolate trust in a universe where there are so many interdependencies and so many opportunities for those barriers to come up, it's no wonder that trust becomes a kind of core issue in limiting our ability to have good outcomes. When we turn to what we're all here today to think about, so diagnosis, overdiagnosis, I've come up with a list, and you'll have more and better things to add to it. But think about just in the diagnostic relationship, all the moments trust shows up. Trust in the need for the test. Trust in whether that test is safe or effective. Trust in the results of the test. Trust in the interpretation of the results. Trust in whether we're having a good shared decision around it. Trust in the things we just heard about, the uncertainty and ambiguity. It's very difficult to trust uncertainty. And trust in a very counterintuitive idea that less is more. I might also say, after hearing Iona, trust in the patient knowing themselves, which is something that we can so often miss. So in a way, overdiagnosis can be an outcome of failure in trust, right? And there are so many ways it can happen. So there's misplaced trust. There's when you might have, as a patient, blind faith in a doctor who historically has been the problem solver, and you've been the compliant person in the relationship. Then there's the misplaced trust in fake news and confusing ads. Then there's a failure of trust in our relationships. So if a doctor doesn't trust a patient, if a patient doesn't trust a doctor, that's setting up the conditions for a difficult diagnostic process, and possibly, leads to fear and all the things that lead to overdiagnosis. And then this sort of transactional relationship that comes into play when you don't really trust each other, where you're just kind of exchanging the bare minimum and thinking what's in it for you, and not really sharing generously what you know, and partnering to investigate together and kind of create a diagnosis together with an understanding of your shared values. Then there's the new kind of lack of trust in the science itself. There are doctors rejecting clinical evidence. There are patients who are afraid that, the medical industrial complex is out to get them, and then they might not be very comfortable, even in a traditional clinical setting, figuring out a diagnosis. They're suspicious of less is more. You have reason to be suspicious of less is more if you're from an underserved community. There are things you can do to kind of take away some of the barriers, and it's familiar to you all, but bringing evidence back into the conversation, remembering that equity matters and that we need to, especially as clinicians, make it known to our patients and our communities that they're safe and that everyone has the opportunity to be healthy. There needs to be transparency all the time in the relationship in both directions. Patients need to be transparent and honest about who they are and what their worries in everyday life are. And physicians have to be transparent about their biases, their conflicts, their quality records. They need to be transparent about the notes they're taking about us. I have worked with an amazing initiative called Open Notes, where patients get to see everything written about them and have conversations about that. And that helps lead to less aggressive care, studies are showing. Then, although regulation is complicated, it also can be a real foundation for trust when we regulate, say, drugs and devices appropriately to protect the public from misuse. And then this notion of professionalism. This is the cover of the Medical Professionalism Charter in the US from the ABIM Foundation. That kind of reminds physicians about their purpose and the kind of intrinsic motivations of medicine. And when you stay true to that, you're more likely to build trust. And then the one I care about as a consumer advocate, this shift in the balance of power. So the ability of a physician to let go and shift some power to a patient who has a lot of power and knowledge about themselves. And really, having that shared decision-making process requires a surrender of power, which is very uncomfortable to traditional medical professionals. So in practice, what examples do we have of success? So the one that I'm most familiar with is choosing wisely. I'm sure most of you know about it by now, which works on overtreatment, but also overdiagnosis. And I was involved in the consumer communication campaign, which was very centered around supporting conversations and having open, trusted conversations between doctors and patients and everyone on the care team. And the core set of questions we came up with for patients was incredibly simple, but incredibly powerful in terms of really kind of vetting your physician around some of the elements of trust and bringing down some of the barriers yourself through asking good questions. So these 5 questions are, do I really need this test? What are the risks and side effects? Are there simpler, safer options? What happens if I don't do anything? How much does it cost, and will my insurance pay for it? And when you start to have a real conversation about those kinds of topics, you kind of get to truth a lot faster. And if there's even a lack of intimacy and new relationship with the physician, those questions can help kind of lead you back to an appropriate place. So we're really proud of how these questions have spread around the world, and in most cases been very fitting across cultures. So I kind of want to end on something, emotional, and that's the idea of authenticity, because in this environment where there is mistrust in our institutions and even our leaders don't trust us as citizens, we as people involved in healthcare need to really model what it looks like to be trusting, and perhaps begin to rebuild trust from the bottom up, locally, because there's an opportunity for intimacy. So authenticity, which puts together the vulnerability and all the things I've talked about, is an antidote to the fake news epidemic, the fake, as I think Iona mentioned in a side meeting yesterday, a fake diagnosis epidemic. Because trust is this very useful idea at the intersection of empathy and evidence. It's where those things can be brought together to lead to a better outcome. It's built through conversations and stories. It isn't just built through guidelines. It requires absolute transparency. It needs to be earned over time if you have the luxury of time. So trust is about the soft things. It's about empathy. It's about cultural sensitivity. And it's about love, a word that doesn't show up in doctor-patient relationships. But if a doctor thinks about love as part of their motivation for what they do, they're not going to overdiagnose. They're going to really think about the needs of the other. So thank you for listening. I look forward to questions.